Good afternoon, everyone. Can everyone hear me okay?
Yes.
Perfect. Well, welcome everyone. My name is Doris C. Ogul, and I am the Assistant Dean of the Office of Diversity, Equity, and Inclusion here at UMKC School of Medicine. And welcome to the 2022 Dr. Reaner and Mr. Henry Shannon Endowed Lectureship in Minority Health. This lecture is part of the University of Missouri Kansas City School of Medicine Dean's Lectureship, named and sponsored in honor of the first Associate Dean of Minority Affairs, Dr. Reaner Shannon, and her husband, Mr. Henry Shannon. The lectureship was created to promote continued learning and education, as well as to bring awareness about medical issues and health disparities impacting people and communities of color. The lectureship typically occurs on the last Friday in February for students, residents, fellows, faculty, staff, and the greater Kansas City community. Dr. Jocelyn Elders, the first African-American Surgeon General of the United States, was the inaugural speaker in 2006. Since that time, the lectureship continues the tradition of hosting dynamic speakers who are local, regional, and national leaders in medicine, including UMKC School of Medicine graduates and faculty members such as Dr. Karan Baucom, Dr. Dana Thompson, Dr. Tim Hickman, and Dr. Michael Moncure, as well as leaders in government and health agencies and professional medical organizations such as Dr. Lewis Sullivan, Dr. J. Nadine Garcia, Dr. Alpha Stewart, and Dr. Patrice Harris. If you're interested in supporting the Shannon Endowed Lectureship in Minority Health, donations can be made at go.umkc.edu/give, and we will put the link in the chat. So before we get started, I just have a couple of housekeeping items. The first one, please keep your mic muted so that we are able to hear our guest speaker, Dr. Weaver, without any interruptions and distractions. And secondly, please place any questions into the chat and we will answer as many questions as time allows. So now I would like to share a little bit about this year's speaker before we begin his lecture. Dr. Michael L. Weaver is a board-certified emergency medicine physician, clinical professor of emergency medicine at UMKC School of Medicine, and a member of the 1971 inaugural class. He served as medical director for St. Luke's Hospital Emergency Services for 17 years and was medical director of the Clinical Forensic Sexual Assault Program for 40 years. He also chaired the Missouri State Advisory Council on EMS for 9 years, provided emergency medicine oversight for Kansas City's ground ambulance for 15 years, and Life Flight Eagle Air Ambulance service for 20 years. In 2006, he was appointed VP of Clinical Diversity for the St. Luke's Health System, and in 2015, he received a certificate in diversity management from Georgetown University. Dr. Weaver chaired St. Luke's Health System's Healthcare Equity Council and was their medical director of equity, diversity, and inclusion until July of 2021. Dr. Weaver is also passionate about giving back and has served in many capacities on behalf of UMKC School of Medicine, such as their Council on Selection and the Diversity, Equity, and Inclusion Council. For the past 16 years, he has led the Critical Mass Gathering event, which is a mentoring program for underrepresented minority medical students. He recently launched a nonprofit, Mission Vision Project KC, to increase the number of underrepresented minority students entering health careers with a focus on medicine. Dr. Weaver's passion for health equity and medical education is incredibly admirable. So without further ado, please join me in welcoming this year's speaker for the Dr. Reaner and Mr. Henry Shannon Endowed Lectureship in Minority Health, the incomparable Dr. Michael L. Weaver.
Thank you, Ms. Agu, for that kind introduction. So let's get set up here. Okay. Greetings and good afternoon to Dean Jackson, Dr. Reaner and Mr. Henry Shannon, faculty, students, and guests. When I was asked to present at the Shannon Lectureship this year, I was very excited and honored for two reasons. First, because the School of Medicine is celebrating our 50th year golden anniversary, and I'm a proud member of the inaugural class. Second, because I'm a URiM member of that class, and I have seen and experienced how diversity, inclusion, and equity can have an important downstream impact on students, residents, physicians, healthcare, and our community. It's also very timely to reflect. We are observing an awakening period around issues of diversity, inclusion, equity, not only from a criminal social justice standpoint, which was brought on by the murder of George Floyd, but also from a healthcare social justice standpoint because of the COVID pandemic. Indeed, a spotlight has been shined on healthcare disparities, the impact of implicit bias, cultural competency, the social determinants of health, or better said, the social influencers of health, because we know that all of these issues don't always determine someone's health outcome. And even more powerful, a book I'm reading on the political determinants of health, which in reality have shaped our nation. We now recognize that racism, not race, is another social influencer of health. And diversity, inclusion, and equity are some of the tools that matter in addressing it. A little disclaimer. DE&I discussions are culturally sensitive and complex. We need to be able to stretch out of our comfort zone because this is how we grow. The discussions are best learned in person in a safe space where you can have a spontaneous dialogue. So Zoom is not ideal. These changes continue to evolve and are time intensive. So it's going to be impossible for me to cover such broad topics in 45 minutes. But I hope through this personal reflection to convince you that DE&I does matter. First, I'm going to lay a foundation by talking about cultural considerations. I did a cultural competency fellowship with the American Hospital Association, and this is relevant because DE&I is all about cultural shifts and realizing that we are all multicultural and living cross-cultural experiences. Second, I'm going to share with you some stories about my personal DE&I lived experience and lessons learned, which I hope will serve as an example of what can happen when one person is given a chance to grow and subsequently can give back to our communities. I'll conclude by discussing each stage of cultural diversity, inclusion, and equity as it has evolved over time and how it matters. There are multiple definitions for diversity, inclusion, and equity, but I wanted to share definitions from our own School of Medicine DE&I plan. It's the inclusion definition that I want to highlight because it's important for this presentation. And many times people confuse diversity with inclusion. In the school's definition, it says, the objective is to create a climate that fosters belonging, respect, and value for all. We'll revisit this point several times during this presentation. So what is culture? You can see here that there are a lot of different definitions of culture, but they are all broad. It's about thoughts, how we communicate, our customs, our values, in addition to race, ethnicity, religion, biology, and other social characteristics. It's also important to remember that cultures are dynamic. They're dynamic in nature and always changing. Culture also has context. What is acceptable in one culture may not be acceptable in another culture. When I started my fellowship, I was amazed with the lexicon of words around culture, cultural competence, cultural intelligence, ethnocentrism, ethnorelativity, ethnosensitivity, and the political correlates of culture, tribalism. We'll discuss more of these in depth. It's important to realize that we are all on a cross-cultural journey and that we typically begin with ethnocentricity. That is being unaware that others have a different worldview than our own. And then you become ethnosensitive and you start to realize that other people have a different worldview. And finally, you arrive at ethno-relativity, where you start to value and respect the different worldviews and cultures that people have. That's necessary to be effective in a cross-cultural situation. So what's a cross-cultural situation? In essence, it's every patient or human interaction. So when we think of culture, we must realize that only about 20% of what we see represents a person's culture. Most of their culture we are totally unaware of until we get to know them, till we talk with them. In this chart, we can see, actually using personality as sort of a proxy for culture, to recognize that culture is not only race and ethnicity, but it's gender, age, your abilities, where you grew up, your socioeconomic status, your educational status, whether you're married, whether you have children, etc. Realize that we're all made up of very different identities that together form our own individual cultural identity. It's estimated that each of us represents at least 80 different cultures. So that makes each of us uniquely multicultural. Although we can never become fully culturally competent, I like the way this graphic represents the cultural competency process. So imagine if you woke up in France. You would first need to be aware that you're in a different culture. Then you would need to have the desire to learn French. You would have to take French classes, learn French, develop French speaking skills, and have real-time cultural encounters with French people. And similarly, this is the process of becoming culturally competent. What's the most important aspect of the cultural journey? It's managing your own biases. And I would invite everyone to take the IAT, Implicit Association Test. So when you think of culture, I'd ask you to remember these things. First, everyone is uniquely multicultural. So every interaction is going to be a cross-cultural interaction. You will never meet anyone with the exact same worldview that you have. Generalize, don't stereotype. And the way I remember the difference is generalization is the beginning of a conversation, whereas stereotyping is going directly to the end. Remember the platinum rule. You have to first remember the golden rule, which is to do unto others as you would have them do unto you. The platinum rule is to do unto others as they would do unto themselves. This is really patient-centered. And remember, it's what the patient wants. And finally, if you don't know, ask. None of us can know all the nuances of every culture throughout the world. Is it important to treat everybody equally? Well, actually, no. As we've said, people are not the same. So you don't want to treat them the same. You want to treat them with dignity and respect, provide care that is culturally and linguistically competent, provide care that is patient and family centered. And remember, it's not about equal treatment, it's about equitable treatment that brings out equal outcomes. So you've all seen this slide. This is the reason that understanding culture is so important. It's because we all come to the game with different experiences. We all need different supports to be able to see the game, which is why actions in diversity, equity, and inclusion are so consequential. Now that we've done some foundational work thinking about culture and the way it influences our interactions, I'm going to shift gears and share some reflections from my lived experiences to show you some examples of how DE in action can turn into lessons learned. However, simplified from an action standpoint, diversity is about being allowed in the room. Remember, representation matters. Inclusion, however, is when you're given a seat at the table and have a voice that is valued and respected. Equity is what happens when that seat and voice influences equitable outcomes. There are several DE&I actions that have created very pleasurable outcomes and given me the ability to communicate and help our community. And I've been able to leverage those outcomes. So I started learning about diversity at a young age. I grew up in the 50s, about 2 miles from the School of Medicine, near 27th and Prospect, on a street called Lockridge. Segregation was still more talked about at that time than diversity. I was very blessed to have 2 parents who were both school teachers and understood the importance of a good education. My house was literally in a red line area. Here's a map redlining of Kansas City. Here's specifically my area, and you can see Lockridge here. Over a span of about 7 years, from 1948, when my area was 98% white, to 1955, where it became only 15% white, this is what we call white flight. The city was very segregated and tensions were high. I remember one day I was walking home from school as a 13-year-old when a helicopter flew over and a megaphone voice said, "Where are you going?" And I was traumatized. And in fact, this led to my first impressions of policing. So why does that matter? I'm painting a picture for you about the lack of diversity and equity in housing and education in Kansas City at that time. Those were the outcomes of segregation. White flight led to a decline in the tax base and therefore the funding for public schools, and that decreased. My parents decided that I should have an integrated education, so I went to Southeast Junior High School. This was about on 63rd and Prospect. So at a very early age, I was gaining awareness that separate was not equal. Next, I want to talk to you about my Rockhurst years. My parents sent me to Rockhurst because they continued to feel that I needed an integrated education. And my parents worked multiple jobs to pay for that tuition. From a geographic standpoint, since I lived on 27th Street, I now had to go further south out to 93rd Street. For an hour and a half in the morning and an hour and a half in the afternoon, I rode the bus to get an integrated education. During my Rockhurst years, there was increasing racial tension because of the riots. The Black student population at Rockhurst was only 4%. There were 0 African-American Jesuits, and of course, there was conscious and unconscious bias. So I got a rather crash course in ethnosensitivity. As an example of one cultural shift, take a look at this picture. Many of you know what this is, but I was shocked when I was asked to join a group of students who were going to go out and TP someone's house. Where I grew up, no one would ever take a perfectly good roll of toilet paper and do this. So I learned how to code switch. I learned about biases, conscious and unconscious. I faced the challenges of cultural identity versus assimilation. Do I get involved in school activities, or do I stay with my tribe and boycott integrating with the Rockhurst culture? I'm now, for the first time in a significant racial minoritized situation. In fact, one day I noticed a group of kids over in the corner laughing, and I asked them, "What are you laughing about?" And they pointed to another kid and said, "Oh, he's Jewish." Now I'm seeing that there are other groups of people who are also minoritized. This was an early lesson in ethno-relativity. So why does this matter? At Rockhurst, I began learning about other cultures. I was predominantly in a white environment for the first time. I interacted with students and teachers that stretched my ability to be ethnosensitive and raised my awareness of ethno-relativity. I learned how to navigate all of these issues in a diversely, predominantly European American educational setting, which gave me some tools that I would use throughout my life. The reason I'm telling you this story is that some minority students who are educated in integrated schools still continue to face these challenges every day. I did get a good, matter of fact, an excellent education at Rockhurst. So now we go to diversity. And here's a picture of me in front of the old health science building when bell bottoms were still in style. I was fortunate to be accepted into the inaugural class. And here's a picture of that class. Much credit to be given to the first dean, Dean Novak, and Provost Diamond for their early intentionality around diversity efforts. By design, 10% of the class were African Americans. That meant 4 of us were in the room. This was an example of an institution using its power to allow diversity that benefited all students in the class. They offered me a Victor Wilson Scholarship, which had been specifically designed to help students who were URiM. Remember the graphic of the baseball game? This removed one of the barriers so that I could participate in the game and I could see the game. That was the financial barrier. And additionally, they had the foresight to understand the critical importance of mentorship and a sense of belonging. That's why they created the docent system. Unfortunately, at that time, not all the docents were supportive of diversity. There was no implicit bias training. There was no cultural competency training, discussions about microaggression in the 70s. However, 2 things happened which ultimately allowed me to be successful and graduate from medical school. First, I was looking for an African-American role model, someone that I could look up to in a healthcare leadership position. I was fortunate to meet the director of the special hematology laboratory section at General Hospital. And I was blessed to be mentored by her. She had a real acumen for cultural sensitivity and DE&I, and she was later to be named the first Associate Dean of Diversity and the namesake of this lectureship. Thank you so much, Dr. Shannon, for all the mentorship you provided to me. Secondly, it was because of Dr. Shannon's close relationship with Dr. Marjorie Searage, whose academic brilliance was only exceeded by her compassion and caring for students and patients, that I was able to move to her as a docent and away from my previous docent. A move that in retrospect saved my medical career and allowed me to graduate and be in a position, again, to give back to the community. My other 3 URiM colleagues were not as fortunate, and I was the only one to graduate with my class. Again, by design, diversity played a powerful role and us as students learning from each other. The School of Medicine sponsored a trip for us to the Eli Lilly Manufacturing Company. And a group of us, after touring the city, went out to visit an establishment. And as we started to enter, I was told I couldn't be admitted. I immediately knew why, but my classmates were caught off guard. Many of them had never gone anywhere with an African American, so they were totally clueless. This diversity lesson, because they knew me, became personal to all of them and had profound impacts that actually reverberated through my entire class. Also, the School of Medicine's intentional design around diversity led me to my best friend, Stan Parman. He's a European American who grew up in the small town of Albany, Missouri. Surprisingly, however, we became great cross-cultural friends. He had grown up as a member of a small flying club in Albany, and he asked me, "Weaver, why don't you get your pilot's license?" I asked him, "Why would I get my pilot's license?" And he said, "So we can fly ourselves out to Colorado and go skiing." I looked at him and smiled, as in an ethnosensitive cultural teaching moment. I said, "Stan, don't you know that Black people don't ski? And they certainly don't fly airplanes." Well, I will tell you, a year later, I had my pilot's license, and we did fly out to Colorado and go skiing. I'm still a pilot. I still go skiing and snowboarding. And all these experiences I'm now sharing with my family and my kids. I belong to a Black pilots organization and a Black ski club, both of which are designed to encourage more African American students to explore these experiences. Here's a picture of Stan, who is still my best friend, was the best friend at my wedding, best man at my wedding, and nominated me for the Take Wing Award. So why did diversity matter at the School of Medicine? By making sure the class started at 10% African Americans, the school was intentional about creating a critical mass, a sense of community, and a sense of belonging for URiM students. We now know these are keys to URiM student success. The schools made attempts to address the financial inequity by providing the Victor Wilson Scholarship. We as students learned about diversity and cross-cultural lessons from each other. These are lessons that we would use in working with other people and in delivering patient care to a diverse population throughout our careers. I encountered experiences that I would have never had if the school were not designed for diversity and had the multiculturalism that it created. I told you these stories because students and faculty are in a similar position today, and there are opportunities for student success in very much the same ways. Because UMKC School of Medicine as an institution demonstrated its commitment to diversity from the beginning, it gave me an opportunity to become a physician, and I was actually invited to give back to the medical school in many ways. For example, after graduating from the school, I sat on the selection council for 13 years. And I think I've had the longest tenure of anyone at the School of Medicine on the DE&I Council. Both of these roles allowed me to help my colleagues understand the different lived experiences of minoritized students. And now I'm going to reflect on diversity and inclusion from my time at St. Luke's Hospital. Remember, inclusion is the next step after diversity. It's not about only being in the room, but it's being valued and respected enough to have a seat at the table and to share your voice. St. Luke's was my docent hospital, and I worked there as an orderly and EKG technician throughout medical school. so I got to know all of the medical staff, departmental leaders. I was actually on track to graduate 4 months early, and the chairman of the Department of Internal Medicine, Dr. Robert Wilbur, who was also very intentional about diversity, asked me to join the residency program. They would have to not only go around the match, but they would have to find funding to start my residency position 4 months earlier if I were to be there. Well, it happened. And this is another example of people in a position of power using their leverage to move the diversity needle. Here's a picture of my residency class. As you can see, I was the only one. So it was even more challenging to find mentorship, a sense of belonging, and community. I actually questioned whether I belonged there and had imposter syndrome. However, as you all know, over time, things change and things are a little different now. Here's a picture of the residency class from this year. As I finished my internal residency, I realized that I loved emergency medicine and started working in the ED at St. Luke's. Luke's was the first private sexual assault center in the entire country. And I started to realize the importance of caring for this vulnerable population of patients. And in the 1980s, right after finishing my residency, the hospital offered me the position of medical director of the sexual assault program. The following year, the hospital made me director of the entire ED. And 4 years later, when the Department of Emergency Medicine was created by the medical staff, I was named its first chair. These are examples of inclusion in that I was given a seat at the table and a voice as well. However, like everywhere in our country, I faced issues of racism. This is how my colleagues dressed in the emergency room. This is how I dressed. Why would I dress this way and wear a suit and tie? You are correct if you thought if I wore scrubs, I would be mistaken for someone from housekeeping or an orderly, anybody but a doctor. I did this because I wanted to create a good what? Well, most would say first impression, but I wanted to create a good second impression. As an African-American man, I realized that when I walked through the door, even before I spoke, people already had their first impression. Was he at the bottom of his class? Or did they have to graduate him because of affirmative action? Seeing me in a tie gave people a way to quickly get to a second impression that I was a competent professional so that I could have an effective physician-patient interaction. I remember one European American female patient that was so upset to see me as her doctor that not only would she not let me treat her, but she demanded to see the head doctor of the emergency room. You can imagine her shock and disbelief when I told her, "You're looking at it." Now, many would be angry about that exchange, but we have to remember we all have our lived experiences. And the reality was that in the early 1980s at St. Luke's, in just about every hospital in Kansas City, it would be incredibly rare to see an African-American physician. So if someone came to treat you, you would be shocked and you would be suspicious. Heck, I was actually looking for more African-American physicians. But recognize that surprise worked both ways. I had some African-American patients started crying, squeeze my hand, or hug me so tight that I couldn't breathe when they realized that I was an African-American doctor and I was going to take care of them. But again, why does this matter? Notice the power of an institution to pull the levers of change. St. Luke's was progressive and made the bold move to inclusion to ask a 27-year-old African-American male physician to take on leadership roles within their organization. They gave me multiple opportunities. Remember Stan Parman sparked my interest in flying? The hospital also made me director of their fixed wing air ambulance program, which I did for many years. I was then asked to be the medical director of the Life Flight Eagle helicopter program, which I did for 20 years. Being included at this level and being valued by St. Luke's credibility opened up many invitations to be involved in outside projects in service to the community. Representation matters. In each of these projects, I showed up with the voice of a person who knows how important it is to ask for the perspectives of marginalized groups, groups that otherwise may have been forgotten. There were a few examples of these kinds of projects where I was able to carry the voices to these various areas. Because I was chair of a level 1 trauma ED, 2 consecutive Missouri governors asked me to chair the statewide council that would establish standards and regulations for trauma sitters, ground ambulances, and air ambulances. Because of inclusion, I had the opportunity to give back as the co-founder of the section of emergency medicine called Clinical Forensic Medicine, and be selected by the Department of Justice as one of 3 physicians on a national level to create national standards about how to care for rape victims. Because of inclusion, I was part of a national effort that led the mayor of Kansas City to designate the first Wednesday of April in every month as Start by Believing Day, where we would focus on supporting and believing survivors of sexual assault. The DoD asked me to teach physicians in the military around the world how to care for victims of sexual assault. The DOJ gave us a $300,000 grant for the state of Missouri to set up a sexual assault network throughout the state. And I received an invitation from the White House to serve on the first national roundtable on sexual violence prevention. And because of inclusion, I was offered the opportunity to help with trainings in Mexico and in Egypt. Here's a slide with my Life Flight team, and you can see me on the St. Luke's fixed wing air ambulance. You all know Mark Steele. We were both ED chairs at the same time at our respective hospitals. Here's a picture of the mayor supporting sexual assault victims. And here's me working in Egypt. And I actually got the opportunity to share my voice in Dubai and spent about 20 years on the Mass Ambulance Service Board. The last part of my time at St. Luke's was focused on equity as part of DE&I. I became more focused on learning to address more systematic issues around the world around equity and to become more informed about DE&I. Why does this matter? Because St. Luke's administration had already demonstrated a commitment to inclusion, I felt comfortable in approaching the CEO to start conversations around equity. St. Luke's was an institution that was now ready to demonstrate a commitment to equity and invited me to be VP of Clinical Diversity in 2006. Another example of the institution's commitment was when Mayor Cleaver asked me to lead a medical mission to Ghana, West Africa. St. Luke's administration was supportive as I raised funds among the 8 different area hospitals to sponsor that mission. The hospital supported my continued education on equity by sending me to complete a cultural competency fellowship, to participate in the diversity leadership program at Mass General, and to get my certificate in diversity management from Georgetown. I was able to get a Robert Wood Johnson Foundation grant to evaluate cardiac disparities, and a grant from the Health Forward Foundation to bring an unconscious bias train the trainer course to Kansas City. That allowed our 3 area medical schools, KU Medical Center, Truman Medical Center, and St. Luke's Hospital all to get this training, which benefited the community. Another example of how inclusion mattered. I continued on as the system-wide medical director of equity, diversity, and inclusion, and the chair of St. Luke's Healthcare Equity Council. This was during a time of growing understanding that health equity is a key component of quality, and the hospital continued to step up. The mantra of DEO leaders is about you can't have quality unless you have equity. It's a very important mantra. So it matters because an institution used its power to be part of the solution on equity. St. Luke's leadership recognized the importance of equity and was supportive in my work, which benefited the larger community. Here's a slide of some pictures that acknowledges some of those health equity projects. Those health equity projects pushed me to want to volunteer as a physician in communities where there were healthcare disparities. We all want to improve health equity, right? I volunteered all over the world because it felt like it was the right thing to do. Here you can see me in India. When Katrina hit New Orleans, all the commercial flight traffic into New Orleans was shut down. I was able to fly myself down to New Orleans, get a temporary Louisiana license, and administer emergency care. Remember Stan Parman? He's the reason I had my pilot's license. But I didn't know that volunteering right here in Kansas City would save my life. When I was a volunteer for what is now KC Care, they had a policy change that all providers had to get a TB skin test. To make a long story short, that clinic's requirement for TB screening led me to an early diagnosis of lung cancer, even though I'd never smoked. I would have otherwise never gotten a chest x-ray. So volunteering at KC Care gave me the greatest gift. And you could say health equity saved my life. Over the years, I became more aware of that healthcare has a workforce problem that contributes to health disparities. We don't have enough providers that are culturally concordant with the population. Only 2% of all physicians in the US are African-American males. So I started Mission Vision Project KC. It's a nonprofit that works with students, mentors, and institutions in Kansas City that are interested in supporting URiM student success. Our goal is to increase and improve the pipeline to healthcare careers. Why does it matter? It makes a difference to students who are in medical school to have that important sense of belonging, a place where they are reaffirmed and valued. When URiM students see each other, it affirms that diversity is a plus for their medical education. We create an environment where students feel welcome and included. Mentorship is a key component to student success, and we want to make sure students have access to culturally concordant mentors whenever possible. Here's a picture of the group from a few years ago. And I want to send out a special thanks to all of you physician mentors who are in the room today. So in summary, I've shared some of my reflections of DE&I as a URI member and graduate of the inaugural class. Because of the School of Medicine's commitment to diversity, 50 years ago tells us some lessons today. The School of Medicine was intentional and created that opportunity for me to be the first African American to do certain things at St. Luke's in Kansas City and across the world, which positively benefited. And our work is now to make sure that there will be many more students who can also serve the community. I was able to do many things because the School of Medicine gave me a chance. I'm very proud of our School of Medicine for its leadership and diversity from the beginning. Now, under the leadership of Dean Jackson, UMKC School of Medicine has continued to demonstrate this commitment by increasing the size and the scope of the diversity office. We now have Dr. Tyler Smith serving in the role as Associate Dean of Diversity, Equity, Inclusion, and she's the first physician to hold this role, so she brings new perspectives. I would say to students, to faculty, and to institutional leaders, each of us must use our influence to make sure that there are more successful URiM students in the future. It takes all of us. It takes action. And here's some things that each of us can do. Embrace diversity. When you have an opportunity to engage with an underrepresented minority student, do it. Invite that person in. Support student success. Remember the baseball fence? We all come to the game with a different place, from a different place and different perspective, and we must do our part to level the playing field and improve equitable access to the game. Increase and create inclusion, not the illusion of inclusion by just checking a box. When you have a chance, make space for that underrepresented minority student to take on a new role or a new responsibility. Support them and give them the tools they need to be successful. Be an ally, be a mentor. Be honest with yourself and see the inequities where they exist. Whether it's recruiting, retention, or placement, work with the school to level out inequities. For example, be inclusive when you think about who gets an opportunity for advancement. Selection council members. Select more URiM students, understanding that they are the next generation who will improve care in our communities. Make sure the class selection is representative of the communities we serve. Get involved. Use your power and influence to advance the goals of the School of Medicine's DE&I plan. Call Dr. Tyler Smith. Ask her what you can do to be supportive of her work. Volunteer and take action. Faculty, you can be additional mentors to students. It doesn't always have to be racially or ethnically concordant. Remember Dr. Marjorie Serage? Students, when you get an invitation to participate in a community opportunity, take it. Be the best at whatever you choose to do. Believe in yourself. Surround yourself with people who will push you to be the best version of yourself. So when you get tired or feel like DE&I is taking a back seat, remember my stories. Be intentional to invite multicultural voices to the table and listen when they share their perspectives. We do this work because it matters to students, residents, physicians, healthcare, and to our communities. It matters and it's worth the effort. Thank you all very much for this opportunity.
Thank you so much, Dr. Weaver. That was an amazing presentation. And thank you so much for sharing all of that insight with us. If anyone has any questions for Dr. Weaver, please put them in the chat. We do have about 10 minutes or so for any questions anyone may have. So I will look in the chat to see if we have any, but let's see. There's some kudos in here and a lot of thanks for sharing your experiences. So any questions and comments are welcomed, but I did have a question. You
Sure.
spoke about the School of Medicine having that passion for diversity with the inaugural class. And why do you think UMKC School of Medicine, compared to other medical schools, had that sense of diversity and inclusion when it wasn't as prevalent in other areas and other medical schools?
I think it's a great question because I think the benefit is because our school was actually brand new. We were actually innovative. So we were thinking out of the box from the very beginning. And as I said before, much kudos to Dean Novak and to Ikre Diamond, because they had that vision. They knew the importance of that from the very beginning and actually designed the school from the bottom up to be diverse. And that's just, we were just really lucky.
Thank you. And I have another question here. It said, how did you handle the wrong docent situation as a lowly medical student?
So again, this was a long time ago, and all institutions had these biases. So the good news was that, again, I was fortunate to reach out and find mentors that were outside the docent system. Again, our namesake today, Dr. Reaner Shannon, and she really was responsible for me to connect with Dr. Marjorie Searage. So, there was an opportunity to transfer away, and again, back then there just wasn't that understanding of the significant impact that unconscious bias and microaggressions can have on students. I mean, we know about that now. We're educated and we try to mitigate that as much as we can. But back then, people just didn't know and understand that. And so I again was very fortunate to be able to connect with someone like Dr. Marjorie Searage, who again, without question, I would not be here without her sensitive and culturally inclusive mentorship.
Thank you. And then we have a question from Dr. Fletcher. It says, we as a country are in another unique window of time. What would be your top 3 suggestions for maximizing this window of time?
So, I think we're all realizing what is it we can do. And I think number one, I would say you've got to keep the dialogue and conversation going. We just can't let this go back to status quo. So that's number one. Number two, so we have to communicate. We have to come together. As I mentioned, this book about the political determinants of health, they are really the underpinning. So we have to be active in what we do. We have to be proactive. We have to be organized. And then finally, I would say that, it's really about taking the time to love and care about each other. We're so divisive now, and we know not only from the Human Genome Project, but through life itself, that we're 99.9% the same. So we've got to get away from these voices that are trying to amplify our differences and bring us together. And it really is about loving and caring about each other.
Thank you for that. And it really resonates that you said that we have to continue having the conversation, because I know with some people, they always think, oh, we've already talked about this. We're continuing talking, and that could eventually cause burnout or people not wanting to speak about it. So that leads to my next question from Dr. Smith, who says, thank you for an excellent presentation, Dr. Weaver. Can you please share how you manage the multiple intersections of your identities to decrease the potential of burnout and to continue doing your advocacy work?
This is one of the things I mentioned to the students. It's really important to surround yourself with people that feel the same way that you do. I'm extremely unfortunate to be, as I said, still nurtured by the medical school. in many ways still nurtured by the community. That's why I started the nonprofit, because I realized that Kansas City wants to take action. They want to be more multicultural. They want to be a more equitable community. And so, yeah, taking the time to seek out people that are supportive, not listening to the people that would be divisive. Those are things that help keep me going.
And you mentioned being nurtured by the School of Medicine and everything that you learned here. And obviously you still give so much of yourself to this institution. And so the next question from Dr. Sullivan, which reads, thank you so much for sharing your experience with us, helps us to put DEI into context. Do you have any thoughts about what the greatest priority for DEI should be for the school? And the second part is, how can the school better recruit diverse faculty when there is so much competition for these outstanding physicians?
Again, great questions. So I would tell you that the biggest barrier for successful matriculation for URiM students at UMKC and many other places is the financial barrier. We've got to get ways, because there are many talented minority students in the greater Kansas City area, and this is part of what Mission Vision Project KC is all about, is that we have to raise the scholarship money. You know, the Victor Wilson scholarship money was critical in me being able to go to medical school, and it didn't cost near as much as it does now to go to medical school. So I think we as a community have to come together and find the funds so that we can increase the percentage. Again, you know, parity is important, and it has a domino effect. So the reason why I call my nonprofit Mission Vision Project is that we wanted to give kids a vision of a successful career in healthcare and as a physician at an early age. So for us to come together, give the kids the vision, and we're looking at, as I said, in that pipeline, so we're looking at even earlier than middle school and exposing kids to racial and ethnically concordant healthcare providers, so that they will see what they could be and aspire to it. And then we need to step up and have the finances so they're able to take advantage of those opportunities once they see them.
And I think you kind of answered a little bit of the next question from Dr. Pearson about, are there innovative ways today that we can increase the number of URiM students in the 6-year program at UMKC?
Yeah, so, and that's specifically with reaching out and networking to the younger youth. So we're actually developing relationships with Sumner Academy and Lincoln Prep and Brookside Academy, a K-8 school, where we're going into these minority schools and helping to expose kids to mentors at an early age so that they can pursue a healthcare career.
And we have another question. It says, Dr. Weaver, what gave you the strength and grit to keep moving forward despite significant challenges as a medical student?
Well, you know, there's a comment that it takes a village, right? And it does. So, you know, first to my parents, who, as I said, realized the importance of the value of a good education at an early age. So I didn't want to disappoint them. But I would say that the medical school was an incredibly, although there were challenges, Stan Parman, Marge Searage, I can't say enough about, again, the ability of them to sort of embrace me and nurture me, and see that I could help give back to the community. So yeah, it's really critical that you surround yourself with people that can be nurturing and supportive to you, because the challenges will always be there. I would love to think that all of the disparities would just go away magically within the next 5 or 10 years. But these are challenges that, again, talked earlier about the sort of the three things we do. We have to come together and love each other and care for each other and help nurture each other.
Thanks. And thanks for that question, Sarah Gomez. So we're at 1 o'clock, but we have one more question I believe we have time for, and it's from Ms. Christine Wankwo. And it says, such a great presentation. Thank you, Dr. Weaver. What are some things your peers did at the time that helped you feel included and supported?
Well, I mentioned that example at Eli Lilly. As I said, it's one thing to read about these sorts of things happening, but when it happens to someone you know, it really makes a difference. It makes a long-term impact. In fact, I will tell you, we had some of the members of my class get together to talk about our 50th reunion, and they brought up that very point. They said, do you remember, 50 years ago when we went to Eli Lilly, what happened? And look at where we are now. So, that's part of, we talked about the cultural journey, and the last part of that was having cultural encounters. So you have to create the time and the space for people to have positive cross-cultural interactions. And that's where you get the nurturing. And when you see other people that are successful, that helps spur you on to continue that drive and that energy. All of you are mentors, have been mentors not only to me, but to the next generation. So all of you that are here, you're here because you're interested in DE&I and that work and moving health equity forward. So I'm just incredibly grateful and thankful of your participation.
Thank you. And Ms. Pamela Shannon put in the chat, great presentation, Dr. Weaver. The Shannon family thanks you for serving as a guest speaker at this year's lecture. And also, again, if you would like to give to the Shannon Endowment, please click or copy and paste the link that Ms. McCommon has put in the link or put in the chat. And also, we also put the program for the lectureship in the chat, and we can maybe, if Ms. McCommon is able to, put it in again in case people did not see it. And again, thank you so much, Dr. Weaver, for being this year's speaker. And thanks again to the Shannon family for this wonderful lectureship series. And good day to everyone. And thank you so much for joining us.
Thank you, everybody.